Diversity and inclusion in medical practice is essential, and while retina specialists always have their patients' and colleagues' best interests at heart, sometimes that message can get lost in translation, especially when it comes to LGBTQ sensitivities. I'm Rebecca Hepp, Editor-in-Chief of Retina Today, and you are listening to New Retina Radio, brought to you by Retina Today and Bryn Mawr Communications. Today, we are sitting down with a panel of experts to talk about ways to foster workplace diversity and inclusion for LGBTQ patients and physicians. Joining me as our moderators are Drs. Vivienne Howe and Basil Williams. Vivienne, Basil, welcome.
Thank you so much for that introduction, Rebecca. I'm Vivienne Howe, a clinical assistant professor at the Kaiser Permanente Bernard J. Tyson School of Medicine in Pasadena, California. I'm also a vitreal retina specialist with Southern California Permanente Group. I'm just very excited to be a part of something that's so important that needs to be done for our field.
Yeah, thanks, Vivienne. So I'm Basil Williams. I do retina and ocular oncology at the Bascom-Palmer Eye Institute. And we're so excited to be here with a number of our colleagues to discuss this important topic. So in the beginning, let's have an introduction from each of our panelists. Jessica?
Hi, I'm Jessica Weinstein. I'm a vitreoretinal surgeon and uveitis specialist at the Spokane Eye Clinic. Thanks for inviting me to the discussion.
Dr. Roberto Diaz is also with us today. Roberto?
Again, I'm a seasoned retina specialist. I've been in private practice. I've been in academics. And I'm currently the head of the retina department at the San Antonio Veterans Affairs Clinic. And I'm also the VA site director for the University of Texas San Antonio Ophthalmology Residency Program.
Great. Steve?
Hi, I'm Steve Sanislo. I'm a vitreoretinal surgeon at Stanford University, and I've been in practice there for about 25 years.
And Brandon?
My name is Brandon Johnson. I'm a surgical retina specialist in New York City. I'm in private practice. Thanks.
Well, thank you everyone for joining us today. Today is really an exciting moment because gathering a group of LGBTQ folks who are open about it within our field is something that's kind of, quite frankly, groundbreaking because it hasn't really been done in the past before and has only really come to the forefront recently because of the progressiveness of Rebecca and Retina Today in their first article in 2021 for the DEI issue. And so now we get to continue that spirit of these sort of issues in this year. And we've gathered together this wonderful group of folks to talk about how we can improve LGBTQ sensitivity, arm the listeners with ways to be more inclusive in the clinic, and perhaps touch on ways they can suggest to their institutions on how to change policies to be more inclusive. So to start us off, Basil?
Yeah, sure. So one thing we'd like to know is, what are your thoughts on whether or not it's important to share your status as part of the LGBTQ+ community?
I'll start by saying that sexual identity and gender identity are fundamental and really crucial to who we are as three-dimensional, fully developed people. And it really defines who we truly are. 30 years ago, I entered Retina as one of the only Afro-Caribbean Latino men, probably the only one at the time. But it was a label I was very comfortable with because it's who I was as a young man. But being gay in field of retina, primarily in the 90s when I started, that was straight, was older, married, white, men, it led me to believe erroneously that the best thing I could do was to do what many of us did or still do, which is hide. You know, hide is a very important word for the LGBTQ community, particularly in professional life. So I thought that Dr. Diaz would be amazing at lecturing, teaching, doing research, running a practice, and that would be enough for me to be in my professional role. And then Roberto could go to gay bars, meet men, maybe boyfriends, eventually meet the man that he legally married, and that I could kind of keep those two worlds apart by being completely in separate worlds. But, you know, family, it doesn't work. So what happens? You know, what do we learn along the way? So in retina, we see patients over and over, and the patients begin to feel comfortable asking you, are you married? Do you have a wife? What's her name? What does she do? Do you have children? What are their names? You know, so there's a time when you decide you can't keep avoiding answering these questions because you really are not ashamed of who you are. So the last 10 years, I decided to come out at work, answer the patient's questions, and because I knew that my sexual identity was integral to who I am, to who I love, to who I admire, to me. And so now the staff, my administration, my colleagues, they all know I'm gay. And it really is a very amazing and powerful feeling because now I can talk about my husband openly. I can take him to annual meetings, talk about my fur babies, talk about my life, and finally allow myself to be my most authentic self.
Thank you, Roberto. We really appreciate some of those thoughts and sharing some of your personal story. Certainly, um, having trained, at a different time compared to where it is today, we've certainly progressed, in terms of our society. And so it's nice to hear how you've been more comfortable today to really share your true identity and how the patients have been very receptive to it. Now, Jessica, I'd like to ask you a question. What have been some of the hurdles you have had to overcome in practice as part of an underrepresented group in Retina?
This is a hard one because I thought a lot about this, but a couple things. I mean, so just first of all, just being a woman in Retina, Retina used to be like a male dominated field in a lot of ways. And now more and more women are in Retina. So, the usual stuff for women, like patients thinking you're the nurse or the tech, or, when is the doctor going to come in? But in terms of sort of my LGBT identity, I would say, a couple of things to play off of Roberto is, when I was a resident, and I made a comment to one of my attendings about feeling included, and they're like, well, you always say, your girlfriend, and you always have to say it as if it's like a badge of honor that you wear. And like, why does that have to be like such a big part of your identity? And I, similar to what Roberto said, I literally had to say like, hey, what about all the people that are constantly saying my fiance, like you constantly hear that in the heterosexual community and it's the norm. And so, I feel like one of the hurdles, or a few times it's been the same hurdle, is like explaining to people how you're kind of left out and you don't get to be part of things unless you come out there and put yourself out there. And I think one of the hurdles is that when you hear stuff like that, you want to be frustrated sometimes, like you feel almost like, hey, why won't people understand me? But I think it's really important to remember that if you're going to get people to come over to your side or understand where you're coming from, you need to have a lot of patience and be prepared to always like come at them from a place of understanding. So you have to be understanding that somebody may be like saying something that you're like, gosh, that's so ignorant. Like, how do you not understand like how that impacts me or hurts me? Being patient, taking a step back, like saying, how can I explain myself to this person? Because sometimes the first thing is to get defensive. So that's one hurdle, I guess.
Yeah, thanks, Jessica, for that answer. Kind of similarly along those lines, I was wondering, Brandon, when you experience situations where you perceive a bias with a colleague or a patient, kind of how do you navigate those? How do you handle those situations?
Yeah, I would say that very, very gingerly. I kind of have two camps that I think are fairly obvious with respect to potential sources of bias, being a man of color and also a gay man. I've kind of experienced a variety of biases and microaggressions, and I think kind of the way that when I kind of realize that I have a patient that may be difficult or maybe othering me in some way, I just kind of fall back on the fact that patients kind of we see patients at their worst a lot of times, and I can't really know what's going on in their heads, and so I try my best to not let the doctor-patient relationship get disrupted if I feel like in some way it is, if they're being rude to my staff, or if there's something discriminatory. I'm at the point in my life where, I have no problem directly communicating that with the patients, but I think kind of meeting them where they are, at least and trying in the service of trying to deliver the best care is kind of what I try to do. That being said, I also just kind of want to put out there that it's also very easy to or it's easy to fall into the habit of just ignoring the topic altogether. I think especially as a gay man, I think because the medical community is so conservative, or at least it was when I was kind of coming through. I didn't really talk that much about my personal life, and I would hear other fellows and other attendings kind of freely talking about their heterosexual lives, and I just kind of kept to myself for the most part. And so I think that does so much damage, mostly to the person who's keeping all of those secrets, which is myself, but then also to the greater community who doesn't realize the pressures that they're putting on minorities. And so I think that's why it's important to have representation and talk about these issues, so that the next generation may not have to be so afraid to be authentic and to be who they really are.
Well, thank you, Brandon, for being open about who you are and being authentic. It's certainly making a difference, because I feel like the greatest way we can change people's biases is just being ourselves. And as more and more people get to know us, like your patients and our colleagues, it's slowly changing people's opinions. It's hard to discriminate against someone when you know someone. And so I applaud you on making sure that the people around you are getting to know you for your true self. Now, Steve, I'd like to ask you a question. You've been in practice now for nearly a quarter, for over 25 years over at Stanford. And so you've seen how policies have changed over the years. What are some office policies in your practice that you find are really important to be more inclusive, so that others who may not already incorporate them, or at least understand how they can make their practices more inclusive of our community?
I actually feel like Stanford has always been a highly inclusive place. I felt like once I was comfortable with who I was, I mean, I spent a lot of my life, not actually accepting my truth, and suppressing even to myself that I was gay. And once I fully accepted that myself and became open with friends and family and things like that, I found no issues. I was completely accepted at Stanford, with the faculty, the staff. It's always been a very inclusive place as far as I can tell. I think certainly there's been a lot more efforts towards being towards adding diversity, and it certainly isn't always the most diverse place in the world. But in terms of being accepting, I always felt very comfortable around my colleagues. And I think the more difficult thing for me was around patients, because with your colleagues, I'd actually, before I even came out sort of to myself, I had been working with a lot of these people, and they knew me as a person. And as Brandon said, and you confirmed, that you don't really tend to discriminate as much against people it's the others that you discriminate against, right? But I think here the biggest one for me was patients. And as Roberto said, patients are constantly wanting to know about your private life. And I have kind of an interesting story. Obviously at the very beginning of my practice, I wasn't out. I wasn't, certainly not to patients. And I would always get, all the little old ladies trying to set me up with their daughters. And I would have to somehow figure out how to answer that. And it was uncomfortable, and I didn't have a husband at the time, and I would just say, oh, that's nice or whatever, and then, after I was married and I came out to started talking to patients, and I would say, they'd say, well, what does your wife do, or how's your wife? And I'd say, well, I don't have a wife, I have a husband, and he does this, and we have these kids, and blah blah blah. Every patient accepted me for that, and then they want to ask me about my kids, and they want to know about all this stuff, which is so much easier to talk about, right? Talking about how great your kids are is a very easy thing to talk to patients. And I've had several patients say, oh, Dr. Sanislo, you seemed a lot more crabby back 10 years ago or whatever, and you seem a lot more happy and joke a lot and stuff like that. So I think if you can't be out and honest with your patients and people like that, you're not going to be as happy a person, and you're not going to have as good a life, and the patients will not relate to you in the same level, in the same way. I didn't really answer your question, did it, Vivienne? But I guess I don't pay as much attention to what, the university is doing. I've been here so long, I do my job and, try to take care of my patients, but I do feel like this is a very progressive place to be, and they do try to work very hard to make it inclusive.
Well, I think that is one thing that's important to point out, is that you already work at a place that's very inclusive. It's a place that's made you feel very welcomed from sounds like day one, and so that you are able to be yourself. So I think that's obviously a very strong policy to have for most places, and to ensure that that's something that is promoted throughout all the different levels of organization, through the staff and physicians as well, and also the leadership level. So that's great to hear that Stanford is such a progressive place, and that hopefully others will be like that, which I do think that things are changing more progressively as well. The AAMC puts out a matriculating medical student questionnaire every year, and they've only recently started collecting information in regards to current sexual orientation. And this year in 2022, or last year's survey, 3.6 identified as LGBTQ. That was at about approximately 16,000 respondents, so that's close to about 600 medical students currently in this year's first year class that identify as LGBTQ. And the numbers are certainly growing in comparison to, I'm sure, Steve, when you were training, and certainly myself back in the early 2000s as well. So certainly the numbers are growing as people are, and I think the reality is many of us just weren't comfortable disclosing also back when we were training as well. So good points to bring up.
Roberto, let's hear your thoughts.
So I was going to say, first, going back to patients, I'm at the VA, and it's mainly men, older, and I don't fit a lot of their boxes. And I've had patients who will say to me, I know you're gay, but that's okay with me. You do good work. So it took me a while to sort of handle that. The first time it happened, I couldn't even know what to say. But I think they're trying to say that that it's okay with them, as long as I do a good job, as a physician. And so, they also will acknowledge that it's okay. Some of these people who you would never think would be okay with it. And a lot of it has to do with the personal attention, the compassion that we give as physicians. And so they're okay with it.
Yeah, Roberto, that's really powerful. And I think kind of Brandon touched on this, and Steve touched on this as well. We're talking a lot about and hearing a lot about your experience and kind of being comfortable in your own skin and with yourself, and the challenges of kind of keeping those things hidden and whatnot. But I do think that's something that the patients can feel to some degree, and definitely your co-residents, co-fellows, faculty, they don't get an opportunity to get to know you fully if you're not expressing the full, complete version of yourself. And so, Brandon, when you brought up that you were a little bit more quiet as a fellow, I mean, if that's your personality, no problem. But if your co-fellows and the residents you're working with don't get an opportunity to know you as well, then I think not only are you being affected by that, the patients are being affected by that, and everyone else around is being affected by that. So I think that's kind of a powerful example of why it's so important to have a diverse and an inclusive environment so people can be themselves and we can all benefit from that diversity. Kind of switching gears a little bit, Jessica, we wanted to kind of talk a little bit about the policy standpoint as well, and kind of wanted to hear some of your thoughts about what's going on the national level and what kind of suggestions you have for organizations to foster the kind of environment of inclusion in Retina.
Well, I think, there's a few things. I mean, some of them you already mentioned. So like in general, just, organizations can have, that inclusive policies and signage and representation. So trying to recruit people who are diverse and sort of keeping out an eye for that, like even looking at their recruitment stats and looking at their overall stats in their organization, like who do we have working for us? What's the diversity there? What's going on? And, if there's deficits or people lacking, trying to recruit those types of people, because I think representation is really important. And then sure, we mentioned Steve works at Stanford, you're in Miami. Yeah. But I used to work in Kentucky, and before that I was in North Carolina, and, I was in sort of medium to smaller size cities. And now I'm in a medium to small size city, but there are a lot of national groups that can still take some of those inclusive policies and make sure that everywhere that they have an office or location that they're applying it to those other places. So, kind of creating a space for people is really important. So, from our standpoint, the AAO and ASRS now has DEI and committees and task force and an LGBT committee and the Minorities in Ophthalmology Mentoring Program, all those things, those are national organizations that are creating these sort of subcommittees and task force to make sure that these things happen. So I don't know if I answered your question completely, but I think, just making sure that you create the space for it to happen. If you don't create an intentional task force or culture or path for it to happen, it's not going to.
Thank you, Jessica, for sharing some of those examples. I think what really emphasizes the point that you brought up was how things have changed really in the last couple of years since the very first DEI article on LGBTQ representation in 2021. Now there are people in leadership. Now there are organizations like the AAL LGBTQ community that didn't exist before. Now there is the ASRS ad hoc DEI committee that also includes LGBTQ representation. So we've really gone a far way in just a few short years since we first started this series of articles. Now, Roberto, I have a question here for you. What are some tips for helping colleagues approach each patient encounter with inclusion in mind?
So, the easiest thing to sort of answer that would be that we all love to learn, and we've been learning our whole careers. So the first thing is we have to be willing to evolve in our awareness of LGBTQ plus issues. So I'll give you an example. Gender identity, right? Even though I'm a gay man, I'm learning a lot about gender identity. I'm learning a lot about pronouns. It took me a while to sort of understand it. My husband, even more confused by what does they mean and how does that make sense? And so, we're always learning. And if we learn, then we engage our patients better. We are able to show more empathy and be less judgmental because we're more open to understanding. And when you're less judgmental, when you show compassion, you are more comfortable, your body language sort of makes more sense, and you're able to really sort of work with that patient. You may not understand them completely, but at least you can sort of share some of the uniqueness of being human and being different. And that's what I would have to tell all my colleagues is you have to feel comfortable acknowledging that you don't know all the answers, that you may not understand, that you are okay with the ignorance, but that you're willing to learn from it. And again, the key issue is just show, empathy. I think that's key.
Yeah, absolutely. And I think, kind of sticking with the theme of education, Steve, what can we do? What educational resources can we seek out as practitioners who want to learn more about our LGBTQ plus patients and their needs? Are there any resources you can share with us?
I don't know about resource organizations, but I did reach out once to a primary care physician who was one of my trans patients, primary care doctor, and their practice is involved with, I think, primarily LGBT trans patients. And I think I learned a lot from speaking with that doctor about, because as Roberto said, we all have difficulties with people that are different than ourselves or different than our groups. And I felt like when this patient first came to me, I treated them the way I treat everybody else. And I didn't realize that maybe I didn't, I could have maybe used some words that were different that might have been better for that particular patient, that, even though I didn't do anything different than any of my other patients. And so after talking with their physician about it, I think I learned a lot. And I think I learned to approach people that are slightly different than myself in other ways, and you don't treat everybody the same. And, you treat everyone the way that you think they would like to be treated. And that's how I learned about that, rather than, I'm sure there are other organizations you and Vivienne maybe know better than I do. But I think reaching out to other physicians, especially who are physicians involved in, that sort of thing. In fact, one of my fellows, former fellow's sister is a gynecologist here at Stanford who specializes in gender transition and things like that. So she's someone I could reach out to as well. So if you can kind of become aware of who those other physicians in your community are, or maybe not even in your community, maybe you reach out to someone in New York or in San Francisco or something, but those people are very willing to talk with other doctors and to help you on that journey.
Yeah, those are some really great thoughts upon that, Steve. And it's nice to hear that personal story about how you reached out to a colleague and they will help you and share. And certainly we have a lot of colleagues within our field that may have certain expertise within this particular area and can also connect. In this connected world nowadays, it's really easy to call up a colleague to help you out. And for those who are listening to this podcast, you have the contact info of all of us now. You actually know somebody who may have resources or can direct you into help with your patients or colleagues. So please take that opportunity to reach out to any of us. That's why we're here and being open about it. But just to share with everybody, there are some great websites. There's great organizations. There's GLAAD, GLAAD.org, that has a lot of wonderful information. Also, the Human Rights Campaign is also another great resource. And also check out Retina Today's DEI articles from the last 2 years. Last year, yours truly wrote an article that actually has a section on a lot of great resources on working with trans folks within the office as well. So check those places out. I wanted to ask Brandon a question here. Being in private practice, but from my understanding, you've also been with a multi-specialty group and also as in academia a little bit. So you've seen different practice scenarios. What have you seen done to help a patient feel comfortable who might be LGBTQ in coming to your office, like in terms of intake forms, in terms of things you've done with your office and policies and questionnaires?
Sure. So I think that really just being in private practice, really the buck sort of stops with the physician owner, and so I set the tone. And I think setting a tone of inclusivity is really important. For example, I have a number of patients who have different gender identifications, and by setting a tone of inclusivity and compassion when I walk into a room and I notice a patient who may be of a different gender identity. I, instead of recoiling or having a reaction that's based in fear and maybe ignorance, I usually try to take a stance of curiosity and compassion. And what I'll generally do is, if I am not understanding or if I have a question, I now, because of my own curiosity, I'll have a knee-jerk reaction where I'll ask directly, what are your pronouns? Mine are he, his. What are your pronouns? And I think that the reaction that I've gotten has been very very positive to that. And so if you can kind of start with that and then trickle down to some more administrative processes, so intake, making sure that you have some options on your intake form for people who have different gender identities, and just making them feel welcome, because the infrastructure that we have set up is binary, and it's just been that way. But that's not the reality of how we practice and how we live nowadays. And so I think kind of breaking down those old infrastructures are really important, and it can start with us.
Brandon, I have some comments about that too. I think you're right. This infrastructure being binary is a big problem, because I feel like if it said on my chart, female, when that's their chosen gender identity, I would know to address this person as a female, right? And if it said male, I address them as a male. If it said non-binary or trans, or non-binary or they, I could know to address them as whatever their preferred things are. I think that would be great. And I think we have Epic here, which most of the academic practices have, and the large practices like Kaiser. There is a way in Epic, this doctor told me, that people can put in their preferred, their gender identity rather than what their sex assigned at birth was, but it's really not used, and it's not something that pops up that you could see easily. And I think if you could have something like that, it would be very helpful, because I personally always kind of feel like I don't want to have to ask someone, because I don't want to make them feel like, for instance, if someone who I think is, has a gender identity as a woman, but I'm not sure because they kind of look like a man too. I feel like if I ask them, what's your gender identity, they might feel like I'm telling them that they're not being very successful at portraying the gender that they believe they are. And that might be uncomfortable for them, and they might not like that. But maybe that's the best way to do it.
I don't always feel the need to kind of to bring it up. But I think that, there are, I'm usually pretty socially attuned. And if there's a situation where I feel like it's relevant, or if I find myself fumbling, if I'm like, if I feel like I might be, misgendering them in some way, that's when I'll ask, and that's uncomfortable. It feels uncomfortable for me to do that, and it may feel uncomfortable for them, but I think that that's a risk that I'd be willing to take, because I think ultimately it may foster a more connected experience with that patient. That's just my viewpoint.
I agree.
I can add a few thoughts upon this topic as a trans woman, and knowing a few folks who are also non-binary as well. I think just the mere fact that one is sensitive to this issue in one's gender, and shows the compassion and sensitivity to wanting to address them in an appropriate manner, simply asking the question about what pronouns they use, for most folks, would not be looked at as something in a negative way. They would actually appreciate that, because I can tell you, oftentimes if that person is struggling with their gender identity or being misrepresented, they often don't get asked. And so for somebody, especially in a environment such as the clinical environment, for somebody who wants to know that accurately, I think would be appreciated. So the other thing is, to Steve's point, making it a policy that applies to everyone as part of your intake. And when you ask anybody, that it's just part of the regular form. So it's within there. Working at Kaiser Permanente, that is part of our EPIC EMR, and hopefully most EMRs are going to move towards that. But outside of that, being asked, I don't think should be viewed as a negative thing. And also another way is just simply sharing your own pronouns as well. So, hi, my name is Dr. Vivienne Howe, and my pronouns are she, her, and hers. And normally that may prompt the person to be able comfortable in sharing their pronouns as well. So just another thought there.
Yeah. So other things that are simple that we can also use. I have to be honest. I don't use ma'am or sir anymore in my clinics because I have been I've gotten in trouble using ma'am and sir. So now I say, good afternoon, good morning. What brings you in? How can we help you? So that I make it very sort of gender neutral. At the VA, without really us saying anything, they did unisex bathrooms. I think that's very helpful. As Steve brought up before, if your intake form has, the legal and the preferred names, it sort of gives you a little bit of a head start before you meet the patient about where they may be. And so when you walk in the room, it makes me a little bit more comfortable knowing that their legal name may have been, Joe, but their preferred name is Susan. And it gives you a little bit more info. I really, with these intake forms, when they use only male and female, I just find that so difficult now because, again, there's all this fluidity that we have to be aware of.
Oh, I think it's just really similar. Like, I think many of us have put our foot in our mouth when you walk into a room and you say something to the patient like, oh, your wife or your husband over here, and you make an assumption, and then it's like their mom or their dad or their sister. And then you're like, oh my gosh. And so I think many of us have kind of changed that, right? Like somewhere, I don't know, maybe 10 years ago, many of us changed that, like stop making assumptions. That's, that's how you get into trouble. And so I think when we're educating other people, just kind of comparing it to something that they've changed or adapted, something like that is easy enough.
Yeah, well, thank you all. This has been a great discussion. Before we go, I want to make sure to give each of you an opportunity to kind of give us a little bit of wisdom and a pearl that you would like to share with the residents or fellows, or just any thoughts that you feel that you haven't been able to express so far. So, Brandon, can we have you kick it off for us?
Sure. I just want to say, thanks. It's a privilege to be invited to this panel. I think you guys are really exposing a topic that really needs to be put at the forefront. I guess my closing pearl would be that, regardless of where you're coming from and, what you identify as and where you are on the spectrum in the LGBT community, really the most important thing that I would, if I had to go back and talk to my 20-year-old self, would be to just be your authentic self as much as possible. And that might come with a lot of pain and hurt and trauma up front, but you either pay it up front or you pay it later. Because I'll tell you, as a 40-year-old who's have repressed a lot of my sense of self for years and years and years, it's affected everything in my life, from interpersonal relationships to just other ways that, my self-esteem, how I view myself. And, I don't think anyone can really be the best doctor if they're split themselves. They're not a whole person. So, growing up and trying to live as a whole person and your to your true nature to the best of your ability, I think that's really gonna allow you to be your best self and the best physician you can be.
Yeah, absolutely. Jessica?
Yeah, I mean, I totally agree with Brandon. I think on the other side of that, I will say, like, I think coming out of the closet or being your authentic self is still really hard. And so many people, we look at the world now through this lens of like, oh, look at how media and everything is representing so much more of the LGBTQ plus community, and it should be easier for people. But I think it's still a challenge. And so my advice is, you try, but at the same time, you can kind of present yourself the best that you can. So like if on the one hand, you're like maybe still not out to like your grandmother on your mother's side, but like you're comfortable with your med school friends or you're comfortable with your colleague, like that's okay. It doesn't have to be like this perfectly made, perfectly packaged thing. And I think that's because that in itself puts pressure on people, right? Because we're saying like, oh, we should all just be comfortable and out, but we all come from different places. So like I wish everybody would be, comfortable and out, but I think it's okay not to have it all figured out yet.
I agree with both what Brandon said and Jessica. I think you do want to come out when it's right for you. You don't need to come out for other people, and it's going to be better when it's right for you and when you are comfortable with it. But I also want to say that it is very hard to change systemic things. So it's hard to change the community you live in or the place you like, as Jessica said, if you live in Kentucky, things are going to be different than if you live in the Bay Area in California. And it's hard to change the organization you work at, some places, and those are all things. But what's easier to change is you to be a leader. And when you're out and when you are comfortable with that and you draw other people to you as an out LGBT person who they respect and they know you're a good physician and a good teacher or whatever, that is going to be the thing that really drives change. I think change is driven more by individual pioneers. You could say Ellen, for instance, or whether you like her or not, people who made a change personally and were courageous enough to come out before the systemic change drives the systemic change. And so I would encourage all of us who are able to, who are in a leadership position, to be our authentic selves and to show how good that can be. And that will drive change in our communities and in our nation.
So I have to say, hiding is a very important concept for us in the LGBT community. We hide as long as we feel comfortable. But I will say that when you hide, looking back the 30 years, I've lost the ability to have great relationships with some of my straight colleagues where it could have been much better. We lose the ability to have good mentors, be gay or straight, because we tend to just sort of retreat and we sort of try to live a very comfortable, quiet life. But I think the aspect of mentorship and friendships are lost along the way. And I have to say, more recently, particularly with the DEI committee for the ASRS, working with Vivienne, getting to know all of you guys more, now I feel that I have friends, that I have mentors that I wish I had 30 years ago.
These pearls that were just shared by our panelists were fantastic. I don't know how much it would have meant to me when I was going through training in the early 2000s to have a group of LGBTQ physicians, just talking about their lives like this. So I'm glad that we're now able to do it for our own trainees, so that they have mentors and they have role models, and for them to know that everything's going to be just fine and they're going to do well, and not only and also potentially excel and become future leaders also. And one of the recurring things that I'm hearing from everyone is that the best way to really change people's minds is through their hearts. And they're doing that through sharing themselves, being authentic, being genuine, and being a little bit vulnerable. I think if all of us were like that more to each other as colleagues and as patients and to our patients, I think our relationships would be much more stronger and much more fulfilling. And I've found that to be the case in myself. So hopefully for all of you listeners out there, during today's discussion, you found that as well. You've learned a little bit about our community. You've learned a little bit on how to be a stronger ally to your colleagues and patients who are LGBTQ.
These have been just absolutely fantastic discussion, and I want to thank each and every one of you for sharing not only your expertise in this field, but also your personal experiences with us. This concludes our episode, but please tune in for future episodes of New Retina Radio.